Okay, greetings and welcome all. It is much to my delight that I make you welcome to this here webinar brought to you by LHEWco. It is a very warm and rainy day. How can it be warm when it's raining? Right? But nonetheless, it's the work of the Lord. So we have to say thank you for that. So welcome. So today's webinar under the title HIV AIDS, is it still relevant? Brought to you by the UAAI Mona Library Health and Wellness Committee, LHEWco. I am pleased to have you here today, and is excited to hear and learn from this webinar. I am Tamar Stretch Heron, Chair of LHEWco, your moderator for this webinar. I will be assisted by other members of the LHEWco team, Mrs. Ruth Rooms Ufar, our prayer warrior, and Ms. Nicole Johnston, who will be monitoring our chat. In today's webinar, we will be hearing from our campus librarian, Dr. Paulette Carr, to bring greetings. Our first speaker, medical officer for the HIV, STI, TB program from the Ministry of Health and Wellness here in Jamaica, Dr. Robb-Allen, presenting under the title, HIV, Looking at the Numbers. And our second speaker, behavior change specialist at the National HIV AIDS Commission in Barbados, Ms. Neblett-Brathwaite, who will be presenting under the title, Behavior Change and HIV AIDS, a Louder Voice. Before we begin, I want to review a few housekeeping issues. Today's webinar will be recorded and will be shared via the library's YouTube channel. We will be hearing from both presenters first, then we'll have our Q&A section to follow. Of such, we invite persons to write down their questions, comments for that section. As a part of today's webinar, we will get you out of here within 1.5 hours. So, please allow me to now invite our prayer warrior, Mrs. Ruth Ufar, to lead the proceedings in prayer. Then you will hear from our campus librarian, Dr. Paulette Carr, who will bring to us her greetings and introduction of the speakers. But just before our prayer warrior comes, please allow me to thank the entire library complement, WJC, Law Branch Library, Science and Engineering Branch, Medical Library, and every section of the main library at all levels for their overwhelming support at the first of its kind, LHEWco's Fruits Day, led by our own Miss Nicole Johnston. LHEWco sincerely thank you, each and everyone, for their contribution. Thank you and welcome, and please feel free to make notes as we go along. Our prayer warrior, over to you.
A pleasant morning, everyone. Let us pray. Father, in the name of Jesus, we come to you. We just want to love you, adore you, lift you up, honor and extol your name. You are worthy to be praised, worthy to be praised. You have made us priests and kings, and we cast our crowns at your feet even now, God. Lord, as we revisit the varying factors contributing to this topic, and as we speak to the different issues, we welcome your excellent Holy Spirit to take note of your ideas, your God ideas, which will be generational. You are God from beginning to the end, and there's no place for arguments. You are God all by yourself. You're an excellent, loving, forgiving, wise, faithful, merciful God, and just. And that is where we come to you today. We look to you for a productive and excellent meeting, oh God. Your thoughts and ways are not ours. And so we have to seek you first for a productive and excellent webinar. Forgive us of our sins, oh God, and cleanse us from all unrighteousness. Thank you, Lord. Thank you. In Jesus' name we pray. Amen and amen.
Good morning to you all. Thank you all for joining us. It is my pleasure to again extend welcome to those of you who are here. And I really want to say thanks to our two presenters, Dr. Robb-Allen and Ms. Neblett-Brathwaite. We are extremely grateful to you for agreeing to make your presentations on this very important topic, which in a way has sort of gotten hidden with COVID-19, that people have forgotten that, you know, we still have this disease. And so we have to be aware of what is happening. And as the library, I think it is so important. And I am sorry that we didn't push this out on the Mona messaging so that other persons within the community would have been able to listen into this to this webinar, especially that we have these very, very important persons who are presenting. I want to also say thanks to the LHEWco team led by Mr. Heron. You know, over the past 2 years with the challenges that we have experienced with COVID-19, the library has I would say that we have come out on top, especially because our health and wellness team, LHEWco, they ensured that throughout the period, throughout the process, while we were focusing on the work strategies, the work from home, you know, we were dealing with making sure the facilities were in right order for our patrons and for our staff. They ensured that the other side, the health and wellness of our staff, was addressed. And they ensured by giving out, tips, sometimes weekly, especially in the early days, notices were put up, but they also had a number of webinars throughout the period. And I have congratulated them on many occasions, and I want to use this opportunity to say that we are very grateful that the library could maintain our health and wellness stance that we really wanted for a number of years, and that it was a success during the period. A few weeks ago, or maybe last week, I did meet with the health and wellness team, and they have presented a fulsome program going forward. We really want to see a greater involvement of our staff within the health and wellness portfolio. We know that number of persons are involved in their exercise program. And as Mr. Heron spoke about the Fruits Day, that it was extremely successful. I want to see a greater involvement of the library. And for us really to be pushing the agenda of the health and wellness team, maybe even more so out, so that there is going to be, did you know that we do have this health and wellness team that provides updates on so many matters that I think can be useful to the entire community. So I really want to, yesterday, as a matter of fact, we had a meeting with our senior team where we are looking at our strategic plan for the next 5 years. And I did ask about the inclusion of the health and wellness portfolio so that we don't overlook it and it becomes a sort of ad hoc on our agenda. So thanks so much to the team for their hard work. And as I said, I'm looking forward to a greater involvement and where they're also working more with, say, our outreach team to get the word out on a different level. We are pleased this morning to have two very informed speakers address us on this topic. And I'm hoping that more of our team members will come into the session so that we are updated on this matter. So we have Dr. Alisha Robb-Allen, who she doesn't know, but I knew her when she was a little girl. And we have Miss Cecelia Neblett-Brathwaite. Our first speaker is Dr. Alisha Robb-Allen, who has been a medical practitioner for over 16 years. She is a graduate of the UWI with an undergraduate degree in medicine and a postgraduate degree in public health. And she's presently pursuing her doctorate in public health. Her interest in public health began while being an intern at a rural clinic in Jamaica, and the idea of being in public health was later cemented. Her active involvement in the HIV program started from 2003 as a medical officer, and this has evolved in her being a program manager for the HIV program for Jamaica, where she is presently the acting senior medical officer for the HIV STI-TB program. Despite involvement in other public health programs, Dr. Robb-Allen has a passion for HIV program and is committed to the improvement and advancement of the program within Jamaica and the Caribbean. So we really and truly welcome Dr. Robb-Allen and the expertise that she is going to bring to us. Mr. Heron, do you want me to do the second speaker? Okay, so Miss Cecelia Neblett-Brathwaite holds a master's in administration and management and a BA in honors in social work from the UWI Cave Hill, and she is presently pursuing an MPhil in social work. She also successfully completed the associate degree in marketing management and certificates in paralegal studies and substance abuse counseling from the Barbados Community College. Her employment history includes tenure at the Queen Elizabeth Hospital, the Sir Winston Scott Polyclinic, the Community Development Department, the Prime Minister's Office, and the Barbados Youth Service and National HIV AIDS Commission. Wow. So I'm seeing here that she has also lectured at the UWI and at the Samuel Jackson Prescott Polytechnic. She contributed to the Better Health magazine and the ILO magazine. We are so honored. Sometimes I say to Mr. Heron, I don't know where you get these, where you get access to these persons who have knowledge, deep knowledge in the areas that we are presenting. So this webinar, and I am glad that it is being recorded, Mr. Heron, right? So that we can share it with other members of our team and we can actually have access to it on our website so that other persons will benefit from what we have. So without further ado, I'm going to invite Dr. Alisha Robb-Allen to speak with us on looking at the numbers in HIV. Thank you so much.
Thank you, Dr. Carr. And Dr. Robb-Allen, you may go ahead.
Morning, everybody. Just want to make sure you're seeing my screen first of all.
Yes, we are.
Are you seeing it on slideshow or not?
No, it's not on slideshow as yet.
Okay.
Yeah.
Is it now on slideshow?
No. Yes.
Yes, it is.
Yes. Mm-hmm.
Wonderful. So thank you very much. I hope you can see me as well.
Yes.
I'm Alisha Robb-Allen. Thank you for that wonderful introduction, and thank you for allowing me to be a part of this webinar. So I'm going to be very technical this morning, and you can slow me down or stop me at any point in time just to make sure we're all on the same page so that you can understand what's happening with HIV within Jamaica. So just an overview. All right, hold on, I'm going to start sharing again. I think I'm having some. All right, so we're going to first look at the prevalence of HIV in Jamaica. What our diagnosis trends look like? What's the parish distribution like? The sex distribution at diagnosis, the age distribution for the last 3 years. What does the progression of the disease look like? And looking at the age distribution of HIV. And then a comparison basically with regards to our UNAIDS targets, looking at our cascade, which is something that we speak about in Jamaica a lot, and internationally when we refer to the HIV epidemic, looking at the Jamaica Stigma Index, and then really answering the question from the numbers, is HIV still relevant? So in Jamaica since 1982, we have had just over 39,000 cases reported to the National Surveillance Unit of the Ministry of Health and Wellness. We have had predominantly male just by 4%. So we have a male distribution of 52% and a female distribution of 48%. They have been reported just under 11,000 deaths. And in 2021, when we look at things, we have approximately 27,000 persons living with HIV in Jamaica who know their status. And when we look at the overall UNAIDS estimate for Jamaica, we really have 32,000 persons living in Jamaica with HIV. So I just want you to look at the numbers in terms of some special categories, because within the HIV response, we have both a general epidemic as well as a focused epidemic. So there are 3 groups that really have a larger number of AIDS cases or HIV cases, and those include the female sex workers, men who have sex with men, and our transgender women. And when we look at our study data over the last 5 years, the prevalence of HIV for female sex workers stood at 2.9%. For men who have sex with men, I'm going through the first column here, stood at just under 30%. And for transgender women, we were looking at 51%. When we look at our epidemiological data coming out of the surveillance unit, persons who would have identified as female sex workers stood at 2.4%. Men who had sex with men stood at 5.6%. And we really had a negligible amount of numbers with regards to persons who identified as transgender women based on our epidata. Now, from our treatment database, and the treatment database speaks to all the persons within the public and private sector that Ministry of Health and Wellness monitors in terms of who are on treatment for HIV. And the persons with regards to female sex workers, there are about 156 persons, just under 1%, that identify as female sex workers. About 5% of the population identify as MSM, and under really a small amount, 0.2%, identify as transgender women. Now, when we look at our general population, outside of these three, we have an overall population prevalence of HIV of 1.4% in Jamaica. So I'm going to try and break down things a little bit more so it's more real to us. So when we look at our cases reported of HIV over the last, since 1982, we can see a general increase up to 2005 and 2006. The blue line represents the overall HIV cases. And then we saw another peak in 2012, and then we started to fall off again, and then another peak in 2018, and since then a downward trend from 2018 to 2021. The peaks have followed suit in terms of the number of AIDS cases, and we saw also in the early 2000s, 2003, that our peak for deaths or AIDS deaths occurred then, but since then we have had an ongoing decrease in AIDS deaths. When we look at persons living with HIV in Jamaica by parish, and this is just the numbers, we can see that in terms of the numbers in areas, the highest number is in Kingston and St. Andrew, followed by St. Catherine, and then St. James. And this fits where our population is. So we need to look at it in terms of our population. What rate is it within our population? And when we look at it in terms of rates, the highest rate of persons living with HIV in Jamaica is in St. James, followed by Kingston and St. Andrew, and then St. Anne. So while St. Anne from the previous slide would have had 2,000 persons, when we look at it based on the population, it is third in the island in terms of places where people living with HIV reside. So when we look at the sex distribution at diagnosis, initially our men led in the persons being diagnosed with HIV initially, and then in the early 2000s, it started to have an even distribution, so to speak, with the women having a higher rate between 2004 to 2008. Since then, it has been a 50-50 distribution. And as I said from one of the earlier slides, when we look at the overall distribution of male versus female, the difference is 4%, 52 in male and 48 in females. Now looking at newly diagnosed for 2019 to 2021, and I particularly pulled out these 3 years because these are the most recent years, and the trend has shown that overall, between the ages of 20 to 49, that is where most of our persons or newly diagnosed are coming from. But of interest is that our 20 to 29 age group has shown more than quarter of the newly diagnosed population in 2019, 2020, and to a lesser extent in 2021. Now, this graph may be a little odd, but I just wanted persons to understand that the orange line represents when people were diagnosed. So you would have seen here that people would have been diagnosed at the age of 20 to 24, 25 to 29, 30 to 34, and some at the age of 50 and over. But when you look at the overall distribution of the current age of persons living with HIV, most of them are over 50. So this speaks to two things. One, or persons who would have been diagnosed at 20 to 24, 25 to 29, and 30 to 34 are living longer. And 2, they're living longer basically because they have access to treatment, access to medication, as well as the psychosocial support needed for management of HIV. And again, looking at the age distribution, I particularly did this slide because of this one where we looked at 50 plus having this huge number of persons. But when you look at the actual distribution, the peak is at 45 to 49 in terms of the total number of persons living with HIV being in that group. But it's an even distribution between 0 to up to 90 plus. Our eldest person living with HIV is 99, and they have been living with HIV for over 25 years. So we do have an elderly population that we have to consider within our cohort. So this just brings me to this. This is the UNAIDS. These are the UNAIDS targets, that Jamaica is a signatory on, that by 2025, less than 10% of countries have punitive laws and policies, less than 10% experience stigma and discrimination, and less than 10% experience gender inequality and violence. And on the other side, 90% of people living with HIV and people at risk are linked to people-centered and context-specific integrated services. So this is what UNAIDS is asking us, has asked us as countries to sign on to. And then prior to 2020, we would have spoken as a country about 1990. And I'm going to start from here. 95% of people living with HIV knowing their status. So now we have moved from 90 to 95. 95% of people who know their status initiate treatment, and 95% on treatment that are virally suppressed. The other 395 speak to combination prevention. So that is not just, that's use of a condom as well as if it be a PrEP drug. And then 95% of women accessing HIV and sexual and reproductive health services, and 95% of coverage of services for the elimination of vertical transmission of HIV. So at the end of 2020, 2019 going into 2020, this is the most recent UNAIDS, published UNAIDS data, the world had identified 81% of persons living with HIV who knew their status, 67% of people who live with HIV who were on treatment, and then 59% of those persons on treatment who are virally suppressed. So viral suppression for HIV speaks to someone who does have HIV, but they are on treatment, so that decreases the amount of virus in their system, and they are then deemed to be virally suppressed. When we look at Jamaica in comparison to the global picture, as well as the then 1990 target, international target, Jamaica had 86% of persons living with HIV who knew their status, 52% of persons who are on ARVs, that's antiretrovirals, and 66% of those who are on ARVs who were virally suppressed. So we are doing well in some areas, and we do have quite a lot of work to do in others. So this is just showing a progression of the last 3 years, and I really want you to focus on the box here in the corner, where 2020, which would have been the onset of COVID, where even though Jamaica had started to make some headway at the end of 2019, we're seeing a fall off to 47% of people who were actually in care and on antiretrovirals. We did see an increase of that to 51%, in 2021. But the one thing that we have improved on, which is a testament to our treatment success in the country, is that we have moved our viral suppression rates, not just in percentages, but also in numbers as a country. So I'm going to move on to the softer side of things within HIV. And one of the more serious things that we are yet to be on top of as a country. So in 2020, the people living with HIV Stigma Index was done in Jamaica, and it was done by the Jamaica Network of Seropositives. And we have to be mindful that HIV is still surrounded by a lot of stigma and discrimination. And this study really brought this out. So it showed that 33% of the participants reported experiencing at least one form of stigma or discrimination because of their HIV status. 53% of participants reported that their HIV status made them feel guilty, ashamed, worthless, and or dirty. 53% reporting symptoms of at least mild anxiety and depression, and 38% reported that anticipated stigma and discrimination delayed HIV testing, and then a further 30% delayed HIV treatment. So I'm going to pause just to say that we have to recognize that the only way we can, one, ensure that persons identify as having HIV is by being supportive as a community. So it requires a lot of behavior change on the part of the persons diagnosed, but it also requires community, family and community support, because persons perceive things, especially persons living with HIV, they have perceived stigma and actual stigma that they experience. And it is one of the harder things to tackle within the HIV response. So just to end with this slide, is HIV still relevant? And the answer is yes. It's still associated with significant stigma and discrimination. There are key populations that are hidden within the general population, so we're unable to diagnose our numbers and then to maintain them on treatment. Though the number of newly diagnosed cases has decreased, there are still new cases, especially in the 20 to 29 and 30 to 39 age group. Lastly, the UNAIDS targets have not been met. In terms of our cascade, linkage to treatment and retention on antiretrovirals continues to be an issue within Jamaica. And while we speak of EMTCT, which is the elimination of mother-to-child transmission of HIV and syphilis, whilst for the last 3 years, Jamaica has improved significantly, we are now starting the process to apply for the elimination of mother-to-child transmission of HIV, syphilis. So we still have some work to be done. Enabling environment and human rights are key areas that have to be continuously addressed to contribute to the ending of the HIV epidemic. So again, thank you. If you have any questions at the appropriate time, I will be available to answer them. Turning over to you now.
Thank you very much, Dr. Robb-Allen. And I'm quite sure those numbers, persons are probably saying to themselves that, oh, I'm glad that I'm over a certain age, but it still doesn't matter. As you say, the stigmatism that is attached to the HIV and the persons being reluctant to get tested, it definitely is a problem that we will have to deal with. And so we will set charge. Again, I'm going to ask persons to write the questions down or to use the chat as our team members are monitoring the chat. All right, so we'll try and get through to as many questions as possible in the order it was received in the chat, or you can indicate by way of showing hand, and we will get you to ask your question at the appropriate time. All right, so thank you very much. And of course, with HIV AIDS, then comes the whole matter of the behavioral change. And this is where we are going to have our next presenter share with us, Ms. Neblett-Brathwaite. And Ms. Brathwaite is going to help us now to understand this behavioral change and tie it into HIV. Ms. Brathwaite, over to you.
Okay, can I go ahead?
Yes, please, go ahead.
Okay, I want to say thank you to Dr. Robb-Allen. I really enjoyed it because actually I'm studying the 50 and over population as it pertains to the knowledge, attitudes, and practices, especially HIV. So I'm really glued, to the presentation because I thought it was really insightful and I gleaned a lot. And I would be contacting you after the presentation so that we can basically see how we can partner in this fight against HIV. But I really enjoyed the session, and I hope that persons take this information and we can create our programs and be proactive in our response to HIV and AIDS. In yesterday's presentation, I was speaking to Mr. Heron. I was saying that, is it really relevant, and is HIV really relevant? I would say yes, it is, because we have so many things to compete with. You have the global warming, we have the poverty, we have all these issues. So I think that this was a very timely webinar at this time with respect to HIV AIDS. So moving along, I just want to say thank you once again. I will be going to the first slide. Okay, the main objective is to explain why it is important to increase the levels of HIV education and to advocate for an extension of the age range after 50 and over. We just heard about the 20 to 49 age group, and we're looking at advocating for the 50 and over because you recognize because of the ART medication, persons are living longer. So we really need to put our focus on young youth, but we still need to find the 50 and over population as an important population to focus on, because you recognize with the persons who are said 90 or over that they're living longer. So we still need to focus on this population. And we also need to provide behavior change strategies that are creative. We have a new society, so we have to provide creative ways to reach our populations. Our objective will be to illustrate these scenarios and messages and with our stakeholders through education, to encourage testing. Next slide. Behavior change in the context of public health, which refers to the efforts put in place to change people's personal habits and attitudes. That is what we basically want to do in behavior change. We want to change people's attitudes and behaviors. For example, with consistent condom use, we have early detection, which is very important. We heard about that before, and to reduce the stigma and discrimination that the doctor spoke to before is very important. We don't want to force persons on the ground. We want to make sure that we see change. Next slide. We're looking for positive direction. After COVID-19, the HIV fight must look to positive direction. So where are we going? Next slide. We're going to be looking here at the behavior change model. We have the preconception stage, you're going up, you have the contemplation stage, you have the preparation stage, you have the action and the maintenance. When we're looking at the precontemplation stage, we're looking at persons who have no intention, they're unaware, they're in denial with respect to the behaviors. And you're looking at the contemplation stage, persons are weighing the pros and the cons. Should I or shouldn't I? These are things to look at the barriers at this stage. And the preparation, we're looking at small, minute changes, collecting information to see if I should or should not. Action stage speaks. The person's getting up and saying, hey, look, I want to make a change and this is what I want to do. We're looking at maintaining these behaviors. So when you maintain these behaviors, you have to avoid the challenges and the triggers and all the barriers. But sometimes in behavior change, you must recognize that would always be relapse. You would be relapsed in anything. You start and then you go back. So there'll be relapse in this situation. And in this situation, it's okay to go back to any of the other stages and come forward because you go back sometimes to get to where you want to go. We're looking here at the issues we need to highlight. The fight against HIV has been reduced because of the following things. As I said before, climate change, COVID-19, sometimes food shortages, war. We have increases in crime and all the financial constraints within our territories because of the COVID-19 situation. Even before that, we had financial challenges. The challenges experienced. We have dearth in information. We have low levels of knowledge because of lack of research. We have risky sexual practices. We have sexual orientations and gender differences. We have the LGBT persons. We have ageism. That's a problem as well. Persons think that because you're 50 and older, you should not be having sex. We have the ethical issues. We have stigma and discrimination. All of these are the challenges that we're going to face in this fight wars we have with HIV. The population characteristics. We have persons who are unemployed, we're focusing on. We have the uneducated. We have few social systems. We have hopelessness. We have anger and rebellion for some persons, some patients. We have information overload. We're tired hearing about HIV. I'm tired hearing about this. So we have to find creative ways to create programs that would capture the attention of our audience. We have the government mistrust. Some persons don't trust what government says. We have conspiracies. Some persons have conspiracies. As it relates to HIV, I can drink my teas, I can use my aloes, I can do all kinds of things. So we have all these conspiracies that we have to work to dispelling these myths. We have behavior change strategies. The doctor just spoke to the 1990 strategy. So I wouldn't go over that, but we're looking at the 90 strategies here we spoke to before. And we need to work harder at, getting towards these 1990 targets that the UN spoke to. Principles of support when it comes to behavior change, an accurate understanding of the barriers to HIV, acknowledge and validate the concerns and apprehensions of individuals, address these concerns and reduce the level of stigma and discrimination, improve customer service within our polyclinics and our social services, adapt to the changing world. And last but not least, enforcing legislation. We need to enforce legislation to have all of these challenges rectified. We need to have it. We're looking at behavior change successes. Strategies to modify risk behavior needs to remain a priority in our prevention strategies. Delay the onsets and first intercourse, looking at decreased numbers of sexual partners, consistent condom use, providing counseling and testing for individuals over 18, decreasing substance abuse, decrease structural activities that seek to contribute to the vulnerabilities that we see, but we can also speak to getting the information out into the schools. We're saying over 18, but we can also get the information out into the schools. In Barbados, we have a transition to secondary school program where we go into the primary schools to make sure that we educate our young ones about the dangers of HIV and STIs and teenage pregnancy. Elements of success, political support. We need our parliamentarians, our medical practitioners, our faith-based, our service providers to come on board with this fight. We need everyone to play their part. Institutional participation and planning, as I said before, religious organizations and the schools, the surveillance laboratories need to play their part as well. Social marketing, that's a big thing we have now, and we need to have our influencers get on board so that it can positively, not negatively, positively tell the young ones, encourage the young ones to practice, safe sex and to abstinence as well. So we need to have our songwriters, and we need to have our artists on board. Social support services as well. What I want to talk about this morning after this slide is that we're looking at some behavior change techniques, and techniques and programs have been impacted negatively. By doing this, we need to speak to persons face to face. I know that we have the COVID-19 situation and we usually use the computer, but most of all, HIV testing and these issues, we need to speak to persons on a one-on-one, and we need to have telephone calls. I know sometimes it can be challenging for healthcare workers. We have to come up with new strategies. Sometimes I have to dress the part. I have to go into the field dressing the part. I have to get my boots on. I have to tie my head down. I have to have my jeans, and I have to go in the highways and the byways so that I can connect with my audience. I can connect with my sex workers. We have to look at creative ways of changing behaviors. Programs work better if they involve the masses, if they involve every person that we're going to target. So you need the schools, you need the churches. I have a new program on board. It's called Grace is Promiscuous, where we're having faith leaders come into the radio station to see how we can create HIV programs to meet the purpose and to target the needs of the parishioners. So we have to find creative ways and means to meet the needs of our persons so that there can be behavior change. We are looking here now at the radical behavior change, the method that significantly is usually focused on significantly large populations, but it can be done with small segments of the population as well. For example, you can have groups of sex workers, come up with their own messaging, come up with condom negotiation techniques, let them have an input into the behavior change process. I had a radio drama a couple of weeks ago where we were talking about HIV, and it came on every day where the elderly can sit and listen to things that they're familiar, that is familiar to them. So all of these are small tidbits of tips that you can use when you're looking at charting the path to creating behavior change, because behavior change is not an easy thing, but it's something that if you work hard and if you have a goal, you can create behavior change. If there's a positive target that you're trying to reach, why do I want to change my behavior? What are the benefits to changing my behavior? And it is to reduce the levels of HIV in the country. We need to look at our or not only our homosexuals, because I was looking at my national strategic plan. I know we have our sex workers and we have men having sex with men, we have all those, but we look at the persons who have relationships as well, because they're not focusing on the situations with their partners because they think that there are insecure relationships. But we must also create programs that target these individuals so that we can meet the needs of each and every member of our society. So I want to just leave the session open so that you can ask Dr. and myself anything you want to ask so that we can ably answer some of your questions and see how best we can work together at creating a new medium, creating new programs that can reach each and every one of us. The churches, we want to reach persons who are on the ground. We want to reach our entertainers. We want to reach our policymakers so that we can let others know that the fight is not over, because HIV is indeed a relevant topic at this time.
Okay, thank you very much, Ms. Neblett-Brathwaite. Quite engaging, and I'm quite sure there are many questions that will come from your presentation. And I have questions for both presenters, but of course, we would like to hear from you, our viewers. So we're going to turn over to Ms. Nicole Johnston and Mrs. Ruth Ufar to guide us through some of the happenings in the chat.
Okay, so we have 3 questions and one person has 2. So the first person who has her question is Miss Anita. All right, her question says, is the provision of medication fully subsidized by the Jamaica government? That's her first question. And would you like me to read our second one for Miss Anita, because Dr. Carr has hers?
If it is related, if it's not related, then I'll ask Dr. Robb-Allen to answer, and then we can ask the second.
Okay.
Okay, so antiretrovirals are covered by the Ministry of Health and Wellness, fully subsidized. They're accessible at all our government sites, but even within some of our private pharmacies, there is a nominal cost associated with it in terms of the prescription fee, but the drugs are heavily subsidized. I don't know if that answers you totally, Ms. Johnson.
And just so to remind persons as well that it's an interactive section, so the mics have been unmuted, so you can react accordingly in an order. Just raise your hand and you will be identified. Okay, Ms. Ruth, next question.
Okay, our next question is, in Barbados, was there any noted difference in the level of HIV cases diagnosed during the COVID pandemic? Should I repeat that?
No, thank you for that. Thank you for that question. I don't think, actually from the information I gleaned so far, I didn't receive any data to bring today with respect to our cases, but what I can say is we recognize as within the world and the region that because of the challenges during COVID-19, our persons were locked down, there was an increase in domestic violence in certain aspects, and persons sometimes did not use condoms consistently. You know, we had an ad in Barbados with respect to, we have an ad in Barbados with respect to that. But what I want to say is that we pushed constant condom use, and we pushed our abstinent messages, and we pushed our testing, and we pushed all of our interventions during the COVID-19 period because we recognized, and we also gave support to our sex workers. We recognized the shutdown, so we made sure that, you know, they were taken care of with our hampers and with our social support. We made sure that that was done. But I did not bring the information about the cases that we have now, but we are in constant support of our target populations and the entire population as a whole.
Okay, thank you very much for that. Just before we take another question from the chat, I have a question of my own. If you both of you will be able to assist me in that, because both of you spoke about the statistics with as it relates to men and man-to-man and the sex workers and stuff. Is there anything specific about male sex workers? Does their statistics speaks to that, or can you speak about that, male sex workers?
It did not bring any statistics dealing with it. I have our national strategic plan I'm trying to go through, but I don't have any information that speaks specifically to male sex workers. I work with female sex workers. I have a group called the Women's Empowerment Group, and we have the Best House that, you know, work with marginalized women as well. But what I can say is that I think that Barbados is trying very hard at providing support for these individuals. Our immigration department has been marvelous working with me in trying to make sure that we meet the needs of our ladies. We might have some persons on our island who may be just renewing their status. And I know that the immigration department have worked with me to make sure that these persons understand their rights, to see if they are even eligible, just to reduce the levels, you know, of sex work that they may be going through, or the challenges that they may be going through as a result of, you know, not being documented, you know, and not having status in Barbados. So we have been working at something from another perspective to see if we can reduce the levels of HIV. We may not have been directly focusing we have been directly focusing actually on the interventions to reduce levels of HIV, condomization, and those things, and education. But we're also looking at making sure that they are empowered as women so that they can find work and they can be employed.
Okay, Dr. Allen, do you have anything you would like to add to that? If you can, if you're at liberty to.
So within Jamaica, we don't do targeted studies for male sex workers. They are, however, covered under MSM population, or men who have sex with men population. And what we found was that the prevalence of HIV within the MSM population mirrored that of the male sex workers, so to speak. So there really wasn't a difference in terms of that cohort of the men who have sex with men in terms of sex workers versus just their sexual preferences in terms of the prevalence of HIV.
All right, thank you for that. All right, let's go back to our chat.
Okay, so our next question is two parts, and it's from Dr. Carr. She says, Dr. Robb-Allen, you mentioned the general epidemic and the focus epidemic. Can you explain the difference? Also, is there a link between COVID-19 and the increase in HIV among the younger age group you mentioned.
All right, so the first question. So there is a general epidemic in terms of general population and a focus epidemic in terms of our three categories of female sex workers, men who have sex with men, and our transgender population. About 20 years ago, our female sex workers would have had a prevalence of in the 20s, but within Jamaica, we have had several interventions with our female sex workers. And so that moved from 25% in the late 1990s to 12% in 2005, 2007, and down to 7% 5 years ago. And we're now at almost 2% when we look at the prevalence within our female sex workers. In terms of our other key populations, because when we speak of two epidemics, a general and focused epidemic, we have to look at what resources are needed to target both populations. Because Jamaica is unique. I would say we're unique in terms of the international setting, but not necessarily within the Caribbean, that our key populations, and our key populations are men who have sex with men, or transgender women, and our female sex workers. They don't identify as such. So a MSM, a man who has sex with a man, they would be in a regular relationship, and let me not say a regular relationship, they will be in a male-female partnership and still be having sex with men, but they don't identify as MSM. So we don't get to capture that as a population because they themselves do not identify as such. So we can't, as a country, just focus on our key populations. We also have to focus on our general population because we have a lot of hidden persons within our general population who do not identify, even though they are part of those populations. So that's one. So that's the reason why I say there are two epidemics going on, a focused and a general epidemic. Is there a link between COVID-19 and an increase in HIV among the younger age group? So the link is not really COVID-19, it really is about our knowledge, attitudes, and behavior within our youth and or adolescents or youth or young adults. We have seen a decrease in knowledge of HIV and sexual practices within our youth, within our last KPB study. And that now has translated in an increase in that population having or contracting HIV. So it really is that there was a change, so to speak, within Jamaica in terms of the visualness of HIV in 2010 onwards compared to prior to 2010. And we are now seeing the impact of that in terms of our youth not being educated and appropriately able to navigate sexual practices and sexual conversations and sex itself. So they are more at risk, so to speak, for contracting HIV. And we have to recognize that every time we put HIV or STIs in a corner, we tend to end up 5 to 10 years reaping these issues in terms of an increase in the population that is not aware of it. So it's and that's one of the reasons why I'm always willing to be a part of these conversations so people understand that HIV is still here, despite everything else that is going on. Over.
All right. I see Dr. Cara has her hand raised. I think you would like to follow up, Doc.
Yes, thank you so much. Dr. Robb-Allen, yeah, I'm a little challenged by it too. And I'm wondering what, since you're working with in that program, that HIV program, can you say if we have like outreach activities lined up? I see the one advertisement which is on the TV, you know, with that young fellow and that girl, and I don't see many others. And sometimes after a while, it doesn't have the impact that we would expect. And I'm just wondering in the schools as well, whether like the guidance counseling programs, whether we are doing outreach in the high schools, because it really has been pushed to the corner over the last few years. And somehow people think that it's no longer a problem. But based on the statistics that you presented, and what is frightening to me is the increase among the young people. So I just wondered if we have programs lined up.
So I'm going to answer it very holistically as best as I can, because we do have a prevention program that targets all the schools, the general population. And then we also partner with the Ministry of Education, and we were part of developing the health and family life education that is implemented in all the high schools, and it does start from the primary school, but there has been a further push by the Ministry of Education to ensure that it's a part of the high school curriculum. So it is unexpected, and it's a subject. It's not just guidance counseling, it's health and family life education. And through that, students are able to learn about sexual transmitted infections, HIV, the whole gamut, gonorrhea, chlamydia, everything. And not just that, but also learning about themselves as persons and developing themselves as persons through this initiative. So that is one avenue that has been started. And it's not new, but it has been around for at least the last 10 years. But within the last 4 years, there has been a greater push by the Ministry of Education to ensure that it was implemented throughout all the public schools. Additionally, the prevention team of the HIV program does do outreach within our schools. And so that is also another area that we engage our youth. The other thing is this, we have to recognize that within that population, and we have to recognize from children are 13 right up until they're 30, regular flow and TBJ, that's not what they look at. We have to recognize that they're drawn to social media. So you will recognize that within a lot of our social media platforms, we are there. The HIV program is there, whether it is through the Ministry of Health and Wellness, the National Family Planning Board, or any of our civil society organizations. There are avenues there that HIV is spoken about, sexual health is spoken about, so that persons, children, teenagers, young adults have the information accessible. So, and I agree with you, having one ad going on, it certainly will not have an impact after a certain time. So what we tend to do is to try and have several flights for the year. So we should be changing that flight within the next month. So there will be another focus of the whole process of HIV management, so to speak.
So there, that seems to be that there needs to be a new thrust for education campaign towards HIV. Ms. Neblett-Brathwaite, you had your hand up.
Yes,
please go ahead.
Our Barbados National HIV Strategic Plan for 2020 to 2024 states that despite its best efforts, the Ministry of Health and Wellness is falling short too of its global strategic targets in 2020. 219 persons need to be diagnosed, 819 need to be placed on our medication, 867 to be virally suppressed. But what we are doing at the National HIV AIDS Commission, we have so many programs looking at prevention. You know, we assist, we have our civil society grants as well, where persons in the community can come up with an idea. They have $20,000 to work with, or could be $20,000, something less or under, where we look at providing support, research support, marketing, and technical support to make sure that we reach our goals and objectives with respect to our national strategic plan. We have the Jabez House that deals with sex workers. We have our transitional to secondary school program, and this is a compulsory program. We'll be going at 11+, and we talk to the students about bullying, gender issues, violence. All these are issues that we deal with. We have our guidance. We work with the guidance counselors in the schools. We have our UB program. We work with the University of the West Indies, KFL. We support them as well in their front towards, you know, reducing the levels of STIs and level of discrimination. And we have our Manoria program, where we work with barbers across the island. That's the man with Mr. Fabian Todd, work with barbers across the island, and we give them financial and technical support so that they are trained, so that when they have the guys come in, they have their hairs cut, they can engage with them, they have the right information to engage with them, and they are trained. And we have a lot of preventive measures. We have a Sister Speak program coming on board. We have radio dramas. You know, we have all these different things that we do to make sure that we get our prevention across at different levels, targeting different levels of our population. We also have the Q in the community as well, where persons are usually 50 and over, you know, listen to the oldie goldies and stuff, excuse me. So what we do is that we sponsor these programs to make sure that our presence is felt, you know, at these areas. We support our footballers, and we had a tennis tournament last month where we supported the tennis activities at the National HIV AIDS Commission, where persons came out and they won prizes. So at every juncture, the Ministry of Labor, you know, we work with them as well to make sure that when persons are going to the Farm Labor program and they're going overseas to travel, that we, you know, provide the knowledge and information here so that they can take back the information with them and they know how to navigate, you know, the region. So all of these are things that we do too at the National HIV AIDS Commission and University of the West Indies as well, to make sure that the message is transmitted to all sectors of our communities.
Okay, great. It sounds like the fight is still real, and we will still try. So, in other words, for us here in Jamaica, we seem to need someone to champion the cause, so that we can get out there on the street and on the social media platform, as Dr. Robb-Allen had suggested earlier. All right, so thank you very much for that. Let's go back to the chat and see if there are any more questions there for us.
Yes, sir. Miss Donna Wallace, she's asking, what's the difference in the average between Jamaica and Barbados since COVID-19?
That sounds like Ms. Wallace is looking at a specific period where COVID-19. Well, let me leave that to the presenters. But it seems like she's asking about statistics for that period.
Well, for Barbados so far, I haven't received any statistics for that period as yet. I don't know if the Ministry of Health and Wellness is working on that area of research, but so far I don't have any data to speak to that issue.
Just before you comment, Dr. Robb, because I thought about something similar to that, and I was wondering to myself if COVID period, especially during the lockdown and stuff like that, if it would have added to the HIV statistics. So I would love to see the response to that.
So I can say that we saw a general decrease in 2020 and 2021 in terms of cases of HIV, but that may not be a true reflection. I say that because during the pandemic, the focus of all our ministries would have been on COVID-19 and not necessarily HIV. So I would expect that within this year, cases that would have probably been diagnosed within our parishes would now just be coming up to head office to be counted. So we may not actually have as big a drop as we see now. So I would give it a little bit more time, I would say until the end of 2023, for us to realistically say if we are really having such a decrease in our HIV cases. It may be that we are, but I would not close the door on that just yet.
Okay, fair enough. Eagerly await that statistics. And is there any more question in the chat? We can take 2 more questions, because I did promise that we're going to get out of here within the hour and a half. And I know it's coming up to a person's lunch hour. And I'm most grateful for those who are hanging around. And a part of staying healthy, which is what we're promoting, is to make sure that you have your balanced diet. So let's see if we can get 2 more questions in before we start to do our vote of thanks.
So far, there's a comment. It's from Miss Fiona Griffiths. She says, I believe the HIV AIDS ads or messages need to be a bit more realistic. What are your thoughts? And could I give a little example of an ad I saw?
Sure.
I think I saw it in it was for a very short stint. Abstinence makes sense. I don't know if you want to use that as an example to address that comment. She wants your thoughts on the ads being more realistic. So I guess it can be thrown out to any of the speakers.
Yes, thank you for that, Fiona. I'm happy that you joined us today. We're looking at evaluating our ads, because we know that we have to restructure and upgrade and make sure that our information is pertinent for the times that we're living in. We had to include COVID-19, the response into some of our ads. And I recognize it is important that we target our specific groups with the information that is relevant and that is trendy and that can bring about behavior change. So we're working at bringing about behavior change, and we're looking at restructuring our programs to meet the needs of our audience. But we must recognize that research must be the foundation of that. So coming out of the COVID-19 situation, as the doctor said before, we are now engaging our partners to see how best we can move forward into this new era.
Well, I'm not too sure how realistic we can be in general media, but we try to be as realistic as possible and to ensure that we are, I don't want to say we are culturally correct, because we have to recognize that not many persons are open to all aspects of HIV. And so that's why the social media platforms provides another avenue for us to be more direct, more pointed in our advertisements and in our data with regards to HIV and sexual practices. Additionally, just as the previous speaker had said, there are assessments that are done on our ads. We do media recall once a year in terms of the ads that have been sent out to see exactly what they have accomplished during that time. And additionally, prior to sending ads out, we assess them in terms of sending them to pilot groups or pilot populations to get their feedback prior to moving it through the process. So I agree that not all ads will appeal to the same persons, and that's why it's necessary for us to have a multiplicity of advertisements and a multiplicity of mechanisms to ensure that we're reaching different populations. Because I can just imagine my grandparents watching the news, and one of the ads that we have on social media that speaks, if you like it raw, go on PrEP. I don't think that would really appeal to my grandparents. So that is not something that would be shown on a national network. However, within social media platforms, those are things that could be used. So it is who really looks on national TV and which population do we need to appeal to, and what mechanisms are we going to utilize to appeal to that population. So I think there's that. So I agree with you that they do need to be more realistic, but they need to be not just realistic, but appropriate for the populations that we're trying to reach. Over.
Thank you.
All right, so I hope that answers the question, and we're running out of time, but I see that Ms. Brathwaite would like to add to that.
Yes, I think that our social services as well should, be proactive to encourage persons to come to be tested and to keep them there. Not only encourage them to have the HIV test, but the social service or the customer service should be improved, and they would want to come back. So that is something that I think is really, really important in the Caribbean. Persons complain a lot. So I think that we have a long way to go with respect to our customer service and meeting the needs of this specific but unique population. Where discrimination, is a really big challenge. So we really need to, up our game in this area.
Okay, yeah. Thank you very much. And it seems like a conversation that can go on and on and on. But we are up on time, and so we thank you very much for your presentation. And at this point in time, I'm going to invite Miss Nicole Johnston to bring to us the vote of thanks.
Hi, good morning all.
Good afternoon.
On behalf of the UWI Mona, good morning. On behalf of the University of the West Indies Mona Library Health and Wellness Committee, LHEWco, we wish to thank you for being here today. A special thanks to our presenters, Dr. Robb-Allen and Ms. Neblett-Brathwaite. Your presentation has been quite enlightening, thought-provoking, and revelatory, and we have learned a lot. We are truly grateful for your presence here today. Many thanks to our campus librarian, Dr. Politar, for her unwavering support towards LHEWco's development. Mr. Boucher and the system team, thank you. To all who are present here today, we acknowledge your presence and would heartily thank you for being here. Thanks.
Thank you too.
Oh, sorry. Thank you very much for that, Ms. Johnston. And at this moment in time, I'm going to ask our presenters to share their final moments, final thoughts within 30 seconds. What are your final thoughts? My
final thoughts would be that the fight is not over, and I want to say thank you to Jamaica Mona, especially Mr. Heron, for working hard every day before the presentation to make this a reality. And I want to thank you very much and thank everyone that worked behind the scenes to contribute to this important effort towards HIV and AIDS. And I want to thank the doctor as well, because I totally enjoyed her session, and I wish you guys all the best.
I just want to mirror the same sentiments that you just gave to the team. It's really important that we don't forget about HIV. And I want to leave two things with the team. One, on a personal note, you have a personal responsibility to yourself to know your status. What is your HIV status? And what is the HIV status of your partner? And two, as a Jamaican, to be more inclusive, more supportive, so that we can decrease stigma and discrimination within our country towards persons living with HIV, as well as to our key and vulnerable populations, so that we can stem the epidemic, because that is what we are missing as a population in terms of getting on top of the HIV epidemic. Again, thank you for the opportunity. I'm welcome to doing more of these on other areas in other forums, as long as I'm given some notice, because I really want people to recognize that HIV is still around and it is still a threat, and we have not ended the epidemic within Jamaica or worldwide. So thank you again for having me.
Thank you.
All right, thank you both for being here and for accepting our invitation here at the UAI Mona Library Health and Wellness, LHEWco, where we are committed to providing you, the library staff and the wider community, with information that is relevant and accurate, that will guide you through making better healthy choice. So being healthy is not just about the physical fitness, but a holistic lifestyle and approach. And we firmly believe that we can achieve this even through our campaign here with HIV AIDS. I firmly believe that we can conquer this fight through education and collaboration. And I think that we will do well, and do see a partnership going forward, because it is indeed still relevant. All right, so I thank you once again for being here, and I will suggest as well, just add that we definitely need to use the social media platform to reach the younger viewers, as was stated in the comment in the chat, all right, to reach our younger viewer audience, right, the teenagers, so we can get that out. And persons really and truly need to be aware that there's no need to stigmatize against HIV AIDS, because as what we have heard, you can, even being faithful to your one partner, that doesn't necessarily mean that your one partner is faithful to you. So it doesn't mean that you are sleeping around, so you can still catch HIV through that means. And if you are sleeping around and you are using protection, which is excellent, you also need to be mindful that you can have a burst condom and you can get HIV. What am I saying? Let's decrease the stigma that is associated with HIV and AIDS, because we have to get this right together, and we will become victorious through this if we attack this fight together as a collective body. So thank you once more for being here. It is now exactly 11:30, and I did promise to get you out of here within the hour and a half. I welcome all persons who would like to share this, and as I said, it will be on the library's YouTube channel. So thank you once again for being here. Very enlightening, and do have yourself a great day. Thank you.
Thank you all. Thank you so much for providing. God bless you all. Have a good day. Bye-bye.
Bye, Jamaica.
Bye-bye.